Welcome back, everyone. This is going to be the session for approaches to relapse therapy. If you happen to be someone who is maybe within that first year of treatment, smoldering, or have monoclonal gammopathy of undetermined significance, let's just say MGUS for now on, you will be meeting in the club room. Have everybody find their seats. There are a couple more people still trickling in. All right. Well, I typically would be in the newly diagnosed or approaches to treating newly diagnosed myeloma room because that happens to be my particular area of interest. However, because of our guest speaker, who happens to be my BFF, Dr. Angela Dispenzieri is going to be talking on approaches to relapse therapy. And it's my pleasure not only to introduce her, but to have worked with her for the last 33 years. Thank you. Come on up, Angela. So Dr. Dispenzieri is at Mayo Clinic in Rochester and has been working in the myeloma space for that long, for 33 years. And she is amazing. Her patients love her. She actually works across the whole gamut of myeloma care as well as other protein-related disorders. And so I will let you come up because she has way too many accolades for me to even remember. But she is my best friend, so that's the most important one.
And we all know Teresa has good taste, so I must be okay. Anyway, so hello, welcome. The way they have it set up is that I do maybe 30 minutes of just going through some of the therapies. You probably heard some about these things yesterday and a little bit today, but we're going to go through that, and then we have time for questions, because obviously those are often the most important things, is really trying to personalize it for you. Okay, so my disclosures. Okay, so what we're going to do is just a little bit of background, and I'm going to focus a lot on the immunotherapy because I know there's been stuff said about all the different bispecifics and CAR-Ts or whatever, but it is kind of confusing, so I thought we could spend some time with that, and again, to general principles, and then some recommendations, because, you know, an approach to relapse myeloma, there's no such thing. You know, because you're all individual. There are many approaches to relapse disease, and so there's no right answer, there's no one pathway. You're all different, and your disease is different, and so again, you know, there's some concepts that hold true, but it's pretty hard to be very specific. Okay. So you saw something like this earlier, and this is basically 77, whoops, it went ahead by itself. Oh, well, that's not good. How do you make it go back?
Sometimes there's a slight delay on the button, but sometimes just click it once, let it load, and then it's good.
Huh?
Sometimes there's a slight delay when you hit the button, but if you hit it too many times in a row, it'll like skip ahead.
Can somebody make it go back? If you can't, I'll tell you.
We can go back.
Okay, please go back one.
Yep.
Okay, so that timeline is basically showing you 77 years back. There it is. Oh, it's funny. What's there is different from what's there. Okay, so 77 years, and you kind of saw that this is not to scale, but 40 years of not a lot of activity. If you look at the blue, we had melphalan and transplant, VAD, which we sort of put away, even though Yellick had it at that time, because that's what was there. And then the next 18 years, there was some more action, and we ended up having a number of different drugs, many of which you probably are well aware of and may have already had. Bortezomib, which is known as Velcade, lenalidomide, Revlimid, carfilzomib, which is known as Kyprolis, ixazomib, daratumumab, pomalidomide. We have also, you have selinexor, isatuximab, ide-cel, teclistamab, we have erlantamab, and we're going to be talking about all of these, talquetamab, and so forth. But you can see in the past 8 years, an awful lot has happened, and so that is really exciting. And when we look at our treatments, whether it's for newly diagnosed or relapsed, we kind of have them in little buckets, sort of groups. So each box is sort of a class, like they share something similar to each other. And so, you know, if you start in the left upper corner, you have what we call the alkylators. That's really the old-fashioned kind of chemo, but it's part of transplant too. And some of it's perfectly good. We don't ever want to forget about it because it can help. But then if you go down, there are things like what we call targeted therapies. Selinexor is something that was approved in the past 5 years or so. Venetoclax is another therapy that's targeted. It is FDA approved, but not for myeloma. So a certain percentage of patients, about 15% of myeloma patients, have in their chromosomes, on their fish, something called translocation 1114. And it appears that the patients who have that translocation are extra susceptible to that medicine called venetoclax. And so that probably will be approved, and we can still sneak it in and get it for patients, even though it's not approved for those particular patients. And then there's something called proteasome inhibitors, and some of the names you recognize, of course, corticosteroids, which everybody loves dearly. But we have our Revlimid and pomalidomide and thalidomide in one box. The CELMoDs are drugs that are sort of the next generation to the Revlimid and the pomalidomide or Pomalyst, and those are not yet FDA approved, but probably will be. And then we have all these antibodies. So the whole kind of right-hand side of the slide is immunotherapy, and we're going to focus more on that. But we have all these different antibodies, and we have things called bispecific T-cell engagers, and then the CAR T cells. And so we have all these little pieces, and as both Joe and Sagar just shared, you know, we're learning how to put it all together because there's so much that's new, and what's the best order? How do you put the pieces together? You do one at a time. Do you do this one first, the next one second? And so these are all questions that are being addressed, and the better the therapy, the longer it takes to figure out if it's better or not. As you get better and better therapies, especially if you're looking to see, you know, overall survival, when patients live as long as they're living now, it takes a long time to get there, which is really good news. But at the same time, to dogmatically say A is this much better than B, it sometimes takes a little bit of work and effort to get there. So I just wanted to run through a few general principles. Therapies change over time, and then clinical trials make this possible. Outcomes. So outcomes like survival changes over time as new therapies emerge. People are living longer and longer. But also, you know, if you have a certain regimen and it was used in people who've never seen a drug from that class before, it's going to work way better than if you try that same regimen in somebody who 3 years ago had that same drug and maybe it didn't work. And so there's all kinds of moving pieces that we look at. If one therapy didn't work well, it doesn't mean that another won't. Terms like overall survival and progression-free survival refer to statistical probabilities for groups of people and don't seal the fate of an individual. So, you know, you have to give estimations, and when we say, you know, progression-free survival with this drug is, let's say, 3 years, that's true. If you had 100 people, yeah, about half of them, you know, would be without progression at that time point. But we can't pick out whether Joe, Mary, George, whatever, you know, whether they're going to be the ones that are still doing great on that therapy or that, you know, it's not working so well for them anymore. So those are really important concepts. And then there's often no right answer at a given point of time because so much is happening so fast. Okay, so I'm actually going to start with a patient of mine, just to give you an example about relapse. I don't know how, like, are there people with myeloma how many have had myeloma more than 5 years? Oh, wow, okay, good. 10 years? Good, that's great. So this is wonderful. So this is one of my patients who's a 17-year survivor, and she had myeloma, and she had what we called ISS 3, so, you know, in that parlance, it was sort of advanced myeloma. And back in the day, we were using mostly doublets. So Revlimid, she started with Revdex, and what happened is her kidneys got kind of funky with that. And so she went on to Velcade Dex, and she had a transplant. And she did achieve a complete response. Now, I'm going to go to the next line, and the scale is different. So when she started, her light chains were 1,200, or depending on which units you measure, 12,000. But as we do better, we're using a smaller scale. Like it goes up only to 200. But what you can see is if you follow the line, so we're going from time left to right, and each of the words going up and down is another regimen. So, the bottom starts at year 5, and she had a remission for about a complete response for 4 or 5 years, and then her disease started activating again. And so then she had another transplant because she was somebody who quality of life it rules. She's like, I don't care if I have to live shorter, I want my life to be good quality. And I'm like, hey, we're in this together, we're working together, we do what you need to be done. And so we had our second transplant. She definitely didn't want maintenance. She's like, I want to ride my horses, I want to do this, I want to do that, and I just don't want to mess with things. Okay, so she did well for 2 years even after her second transplant. She relapsed, we tried something, a little bit of benefit. She went on a clinical trial. She then moved to, Darapom Dex. Then we moved to venetoclax. Now her numbers, you notice, are not at the bottom, up is bad and down is good. But she's living with relapse disease. Her numbers aren't perfect, but she is having a great life. And so, numbers are important and trends are important, but it was even said, MRD, sure, it's a goal. On average, if a regimen produces higher MRD rates, that's good. But that isn't the whole name of the game. It is that we're keeping the disease under control and that people are living their lives. And so, she was sort of, doing okay, not perfect numbers, but holding her own with different combinations with the venetoclax. And then she went on a clinical trial with one of the bispecific antibodies. This one isn't approved yet, but she did that for a year, and whew, her numbers did great. She was in remission, and MRD negative even, but she had one of the complications that we know happens with these immunotherapies. She ended up with wicked infection. So she had to come off the clinical trial, and she recovered from her infections. And we said, well, let's just hang tight for a while. In theory, we're supposed to continue indefinitely, but we couldn't because the trial, that wouldn't allow it. But she went for a whole year with no therapy, still in remission. And then, she started relapsing again, and we tried a CAR T. It didn't really work for her. But then she went on good old-fashioned carfilzomib or Kyprolis, and it's a year and a half, and she's doing really well. But this is a journey. It's you guys that have been around for a long time with this disease. I don't know how many have been in, complete remission for the whole time, or you've kind of had to dig into different therapies here and there. But sure, it's nice to just be in remission forever, and that's our ultimate goal, of course, but people can live with disease, as she is a perfect example. And so, she, 12 years, 13 years after her first relapse, she's still doing well. And as mentioned, not in CR, but good quality of life. So let's talk about immunotherapy. So again, the whole idea here is we want to train or retrain the immune system to kill myeloma. Our immune system is to fight infection, but also it's supposed to do surveillance. It is supposed to keep these antisocial cells in check. These cells that want to be cancer or cells that are cancer. The immune system shouldn't let that happen, but somehow it does in myeloma and other diseases. And so the idea here is, how do we train the immune system to work as it's supposed to work? And so a lot of what we do is with using lymphocytes and sort of these T cells are kind of what we're really engaging in a lot with the CAR T and the bispecific T cell engagers. But here's a cartoon, and it is kind of busy, but what I'm showing you in there in the middle is that big blue blob is the myeloma cell, The darker blob inside is its nucleus. And then it has little red things around it. And those are little, what we call antigens. They're little surface proteins that every cell has, and there's a whole assortment of them and so forth. But what we do with immunotherapy, the goal is we say, are there coatings or decorations or antigens on the myeloma cells that are mostly only on myeloma cells and plasma cells? We don't want to have that same target, in your brain, in your brain or your skin or your gut or whatever, because if we're going to stimulate the immune system to hurt things covered with this, we want it to be very specific. And so there are a number of different targets that they weren't put there to be targets, but for our purpose, targets that we go after. And then there are different ways that we go after it. And those are the various types of immune therapy that we're going to go through. And this idea of this targeting, it's kind of that lock and key thing. Just not any lock and key are going to go together. Okay, so you got the naked antibodies, which are just that little Y-shaped thing. The four-pronged Y-shaped thing is an antibody. It's a cartoon of an antibody. And basically, it's going after that myeloma cell. And so those naked antibodies, daratumumab, isatuximab, elotuzumab, I'm sure you've had at least one of these, or many of you have maybe encountered, but they are recognizing different coding. So daratumumab and isatuximab, they recognize something called CD38. And so that's the decoration or the coating on the cell that it's going after. Elotuzumab goes after something called SLAM-F7. When we get into a lot of the newer immunotherapies, and this is what we call an antibody-drug conjugate, it's going after a coating called BCMA, or B-cell maturation antigen. And that is something belantamab or Blenrep. And that had been FDA approved, but then it was taken away off the market because it didn't meet its ultimate endpoint. There was a trial comparing it to pomalidomide, and it didn't have better progression-free survival, even though the response rates were better. But now there's some interesting data that are showing that maybe it may come back. It's still approved in Europe. But what it is, you have that antibody, but there's a toxin, a chemical that is very poisonous to cells, and so you're bringing that toxin directed towards the myeloma cells to help kill. And so this is just an example. This is a DREAM-7 trial, Velcade-Dex with belantamab or daratumumab. So everybody got Velcade-Dex, but you either got the antibody belantamab or you got daratumumab. And the idea is you want the line to be higher. And so the red line on the left is the belantamab, what we call progression-free survival, alive and without the disease getting worse. And the blue line was the Velcade-Dex with daratumumab. So very promising. And even on the right, when we look at survival, again, the red line is over the blue line, higher than it, so that seems that it's better. And based on this, I suspect the drug is gonna come back to the US. And there was another trial using Pomdex with belantamab or Velcade, pomalidomide, and again, the curves with the belantamab look good. So we will see. But moving to what we call the bispecific antibodies. So there are 3 drugs approved. And what I have here is the purple is the myeloma cell, and then the green is a T cell, and then you have that funny Y with the 4 prongs. And essentially, that is the drug, these bispecific antibodies. One arm, so to speak, is reaching out and sort of grabbing onto the myeloma cell that has the BCMA on it, and the other arm grabs out to the immune cell, the T cell, and it basically is like, here, look, this is bad, kill it, it's bad. And that's really the way these things work. The 2 that are FDA approved, teclistamab and erlantamab, are basically, again, the target they recognize on the myeloma cell is BCMA, just like I showed you with the belantamab. And then there's something called talquetamab, which is recognizing something called GPR C5d, another different coding. And so, we're trying to figure out how do you, organize this, like once you've had one BCMA, anti-BCMA, can you have another anti-BCMA? I think it was, I can't remember if it was Joe or Sagar who said it, but, the myeloma cells get smart. And, if you give it something targeting BCMA, can you give it, again, a different thing targeting BCMA? That may not work so well, or maybe you need a certain amount of time before that'll work for us. So just a little bit of a summary point about bispecific antibodies, the T-cell engagers. Overall, about 60% of patients will respond to these therapies. Their myeloma numbers get better, their M spikes get better, and they tend to be deep responses. And if there is a response, it lasts about a year and a half. That's an average. There'll be some shorter, there'll be some much longer. There's less what we call cytokine release syndrome. You guys heard about that already? Teresa, did they hear it, or it's coming? Later, okay. Cytokine release syndrome, which is basically an activation of the immune system that can make you very sick while you're getting the therapy, usually the first few doses. And so it has less of that than the CAR T does, which we'll talk about in a moment. And then a big thing, serious infections in about a third of patients. So like that patient I shared with you, she had a serious infection. We use intravenous gamma globulin or immunoglobulins to sort of replace some of the immune stuff that we are sort of getting rid of with our therapies, because again, although we're stimulating the immune system, we're also blunting a part of the immune system. These are very handy because they're off the shelf. You don't need anything special. Your doctor can just have it infused in without any special preparation other than, we do dose escalation and stuff because of the cytokine release and all that. And currently, these drugs, you have to have had 4 prior lines of therapy in order to get access to these drugs. So it's later in the course of the disease. And they are cumbersome because most of them start out weekly, and the way the trials were originally done, every week you come in for infusion. Some are subcutaneous, so it's not that bad, but still, not going into the doctor's office every week is a little bit of a bummer. There's every other week dosing after you get to a point, and there's some that are looking at every 4 weeks, but again, a small problem. Talquetamab is one of the drugs that has a slightly different mechanism in terms of bispecific. It's given weekly or every other week. It has less infection than do the other BCMA bispecifics, and response rate is about 70%. But there can be troubles with taste and nails and skin because, again, that coating that that surface marker that it's going after is also expressed on some of the skin cells and sort of the epithelium of the mouth. And so that's a side effect. Some people don't have those issues, but others do. But just to sort of share, if we look at, so this is sort of a summary about bispecific antibodies and sort of where we are with them. We're trying to figure out when is the best time to use them. It was alluded to in the last session, maybe it's part of first-line therapy after CAR T, all kinds of questions. Is that the best time? When do you use it? Is it better to use before CAR T, after CAR T? Do you use it in combination with other agents? And what these little blue bars represent is the response rate in this sort of foray into using combinations. So the first bar showing 78% response rate is combining talquetamab with daratumumab, and the next one is showing talquetamab and teclistamab, and these just various kinds of combinations, and what are we seeing? So there's just a lot to learn, and the data are emerging just about every day. And then finally, moving to CAR T, so there are 2 FDA-approved drugs. Both of them target that coating called BCMA. And again, the myeloma cell is that purple guy up at the top, and then the green is this modified T cell. And so it has the sort of the arms, it's 2 arms instead of 4, but it is really part of the T cell. It's not just an in-between. What has been done is that the cells, the lymphocytes, are taken from patients, kind of that procedure, leukapheresis. It's very similar if you've collected stem cells. The machine is a little twisted, it changed a little bit, but we're collecting those cells. It's one session to collect the cells, and then those cells are modified. They're the gene for this chimeric antigen receptor is put into them, and those cells are grown up, and then they're given back to the patient after some what we call leukodepletion therapy, just a little bit of immune suppression to make sure that they can find a nice space, and then basically they're there to kill myeloma. And again, the time from arm to arm, they kind of call it, from getting the cells out to then putting a product in, is typically at least 4 weeks. There's some agents that are being experimented with that are, more like a week from arm to arm kind of thing. Because 4 weeks, if you have an aggressive relapse, is a long time to wait. And so that is potentially, a drawback to the CAR T. But the benefits of the CAR T, we have very high response rates, 75% of patients improve. Currently, no maintenance, though Dr. Loniel Sagar told us that they are experimenting with using some maintenance in this setting. There's no steroids, no dexamethasone, and we show benefit in patients who have had a lot of lines of therapy. But I'm not going to go into this very much, but there are risks. The most profound risks are the time, right around the infusion. And so that's kind of a timeline, kind of that first week, and that's where a lot of times patients are hospitalized or seen on a very regular basis as an outpatient and have remote monitoring or whatever. And then there's some neurologic stuff where people can get delirious and confused and things like that. And they can even have seizures and stuff. So nothing's for free, but most people don't get these things, but it is a risk. But the really interesting, and I know this is a busy slide, but the really interesting thing is there have been now clinical trials looking at using it earlier. So if you kind of focus on, is this a pointer? It doesn't matter. If you focus on the first two columns, or the column 2 and 3, those are using ide-cel, and the columns 3 and 4 are using cilta-cel. And what you're seeing is in the first column under KarMMa, those are patients, that was the original that got it approved, FDA approved, and the number of lines of therapy those patients had was 6. Okay, but they did another trial. They said, well, let's look using the ide-cel in people who've had only 2 to 4 prior lines. So the average number or median number of lines was only 3. And then they said, well, they didn't actually compare. The slide is made up to put them side by side just for an illustration. But the expectation that I think many of us had is that there would be higher response rates and longer progression-free survival. But interesting that progression-free survival, meaning alive and not progressing, the myeloma not progressing, was really very similar, 12 months versus 13 months, whether you were very delayed in your disease, had been through a lot of therapy, versus whether you had it earlier, whether it was done within 2 to 4 lines. And similar, the other product, the cilta-cel, same type of clinical trial. Their original one, that second kind of light blue column, 6 lines of therapy was the median. The early was, for this second trial or this other trial, 2 lines of therapy. But when you look at the overall response rate and the CR rate and everything, they're not that different, 95 versus 85%. And again, at 12 months, the number of people progression-free and alive is comparable. And so, I personally was surprised. I would have thought, it would seem that much better. But we need to learn so much more. We have to follow patients longer. But what this does, that trial gives us, or both of these trials, the KarMMa-3 and the CARTITUDE-4, is that the drugs are available at earlier lines. So up until about, 6 months ago or something, it was that you had to have, quote, failed 4 prior lines to get access to these drugs. Now you can get access much earlier. It's approved and insurance should cover it. So again, questions with CAR T. When do you use them? we're not sure yet. We're figuring it all out. Again, we think it's probably better to be using these before the bispecific antibodies, especially if you're going after that same coating or same BCMA therapy. But do you use maintenance after? Do you use it with other drugs? We're really excited about faster production, products that maybe give us an even longer duration of response, products that could be made from the stored cells you have in the freezer that for maybe your second stem cell transplant that you haven't used, and also new targets. And so we're learning a lot. So back to general principles. If we look at, so what I'm showing you in blue is the overall response rate of different regimens. So in each of the lines are going across horizontally. So the percent of people responding is the blue, and then the green is the duration or the progression-free survival. And if you notice that as you go further to the right, those are bigger bars, showing you that those immune therapies, the talquetamab, the teclistamab, the erlantamab, the ide-cel, the cilta-cel, something I didn't talk about, which is a CAR T after that is not approved, but it is showing really good effect, and it's after the GP6-5D target. All of those have really high response rates compared to our old favorites, pomalidomide, carfilzomib, daratumumab as a single agent, selinexor. And even the green bars are also going up. The progression-free time is even better. And so it's very exciting how much has been going on in these past few years with just individual therapies offering much better outcomes. So the good news is that there are many treatment options. The bad news is there are many treatment options, and the only way it's bad news is that it's confusing. We can't say for sure sometimes do this versus that because we just don't know yet. But overall, it's great to be having so many options for patients. And again, as we think about what's our approach to treating a patient with relapsed disease or even new drugs or approaches to treat disease, we're always thinking, what's the tolerability of a regimen? What's the sequencing? Is it bad if we use this drug up front because then we don't have it down the road? Don't know. How long do you use it? We'd love to have limited duration therapy. How does that all work out? It's true in newly diagnosed, it's true in relapsed. And then even the dosing of different therapies. Again, we're learning with some of the bispecifics, they don't really necessarily have to be every week. The AbbVie bispecific, which isn't FDA approved, is dosed every 4 weeks, and it seems to work quite well. So again, a lot to learn. But then the other really important and interesting thing is that there's something called synergy. When you basically put sometimes 2 drugs together or even 3 drugs together, the whole is greater than the sum of the parts. That's where I have 1 + 1 is, greater than 3. It really is, sometimes there is an interaction between these drugs, and they really are, it's important to have them together. And then there's what we have clonal tides, where disease sort of goes through sort of different phases. That, when you have your myeloma, we talk about it being a clone, but each of your myelomas, it sort of has its own little evolutionary life where mutations occur and it derives slightly different features and characteristics. And so, you may be your disease may be responsive to one therapy, but then it's not responsive down the road because, again, those sensitive clones have basically been killed, and now you have the resistant clones. And so there's a lot to think about. I would direct you, I have some slides on, how do you treat first relapse, second relapse. It's a bunch of just flow charts, but we put at Mayo out there for anybody to look, how do we deal with first relapse, your second line off study, and, different conditions, refractory to lenalidomide, not refractory, second or later relapse. You can just go to those web pages, but for me to talk through it, I think you'll all be asleep very quickly. So I'm not going to really do that exercise, but I'm more than happy to, talk through specifics and clarify things. But that's kind of the approach, but I want to leave you with the idea. I mean, the future is bright. There is so much going on in this space. I've been in this business, for almost 30 years with myeloma, and it's unrecognizable in terms of the duration of life that patients enjoy, the quality of life that patients enjoy, and just the opportunities. So with that, I thank you for your attention, and I'm happy to answer.
So with that in mind, we've got hands already going up. This is our time to do Q&A, and something people I want for you to do, knowing that this is complex and only going to get more complex, make sure that you are creating a journal, a timeline of your own treatment history, because you're going to need to know that. Eric.
Thank you. So regarding CAR and trying to extend that time before the disease comes back, Dr. Laniel mentioned that his patients, he puts them on maintenance. I read a journal article a week ago that talked about CAR-E. So it was some sort of enhancement, some sort of additional treatment that was given after the CAR-T was given to do just that, to sort of keep the T cells up, alive, engaged, because they die off at some point in time, right?
Yeah, and so I can't say I know that specific article. I apologize, and I could look and give you more, but I can tell you just in general stuff, because there are things that are, you see at meetings, and then when they are published, they're a little different. But so there are different constructs that are, trying to actually keep things around longer. There's a couple of things out of China where they have longer persistent type of CAR-T. So that's one. There's work using what we call checkpoint inhibitors, trying to upregulate the sort of the immune system so the CAR-T may work better. The Revlimid data, I think in some we know that it's immune enhancing. For those few patients, it's sort of out of fashion to do an allogeneic stem cell transplant in patients with myeloma, but we saw that if a patient had an allo and you give them a little Revlimid, you can put them back in remission if they're relapsing after. So there's all these different ways of trying to modify the immune environment, and either through persistence or through just, again, affecting the milieu. But I can't specifically address that article, but happy to look it up and go over it with you if you like later.
And I apologize, I should have mentioned Eric is one of our support group leaders.
Sure.
And he's on top of it, man.
Yeah,
I'm telling you.
There you go.
Yeah. Thank you for your talk, but I have a question about the synergy idea. Bartolome, I'm probably saying his name wrong, the old pioneer.
Barloghi, yeah.
Yeah, Barloghi. He always believed in like 8 or 7, treatments all up front. But it seems to me like over time that was sort of drifting that way. 2 is better than 1, 3 is better than 2, 4 is better. So I'm wondering if anybody's looking at his old stuff that was about 8 in the beginning.
Yeah, and so, the drugs that he used, they were all very similar to each other. There were a lot of alkylators, and there are a lot of medicines that we don't use anymore. But his concept of the idea of using everything that you know that you have up front, do it sequentially, and then do some maintenance and consolidation is an approach that was just talked about, before the break. The idea, if you kind of keep at it and you come at it from all different ways. The hard thing is you don't know until you get there, whether you're sort of, by doing something, you're blunting, you're having the opposite of synergy. You're having some kind of antagonism or whatever. And that's why these things, people can make stuff up all the time, but you really need to do clinical trials to understand, is this really better? And so, but his concept, which is really, he borrowed from acute leukemia, is very much the approach that people are taking and going more in that direction. But the drugs used are just obsolete at this point because we have better stuff. Yes, Teresa.
I have a question on your philosophy of when to treat biochemical relapse.
Yeah.
You know, we hear, okay, now with a 4-drug regimen on newly diagnosed, let's hit this thing really hard.
Yep.
Then with biochemical relapse, you hear, well, let's watch and wait.
Yep.
And for me, sometimes that feels in conflict with let's catch it early, or
So again, that was a little bit, it's a great question. You know, it was touched upon at the last session as well. You know, most of us don't treat with just biochemical relapse. The concern, number one, is that you don't want to hurt the person. You know, we can, as a physician, you know, we can flog patients till the cats come home, but that's the antithesis of good quality of life and all the rest. There is precedent where, you know, more treatment can be harmful. Again, in the modern day, we haven't shown that, but certainly in the old days when we only had alkylators and things, we found that we were giving people, you know, high rates of acute leukemia and things like that. And so, you know, you want to put your toe in at the same time. The other thing Joe also shared, he said, you know, sometimes maybe a clone is coming up, a little minimal residual disease, but maybe it's not an extra wicked clone, and maybe its presence is suppressing, you know, maybe one of these more aggressive clones. So we can theorize and hypothesize as much as we want, but we don't really have the answer. And for something like that, you know, the end point really would be overall survival. You'd have to measure, and there are people looking at various things, you know, when do you stop therapy, you know, a little bit treating with, you know, as you're gradually coming up. But those trials, literally, to get a good answer is 10, 20 years, because patients are living longer and longer, and so it's a very hard thing to address. But, you know, we don't treat MUGUS, we don't treat early smoldering, and so, and maybe, certainly you never want to treat MUGUS, period. I mean, I can't, unless it's some kind of magical, you know, hormone or, you know, a leaf to chew or something, but smoldering, you know, maybe we'll creep back and treat more and more smoldering. So, but it's that balance of not trying to do harm. But it's a great question that just doesn't have a perfect answer. The other is the reliability. If you treat somebody, what's the reliability? You know, you stick a needle in the bone marrow, and myeloma's patchy, you know, so you were MRD negative here, and, you know, then you're there. It could be, you know, a little bit positive or something like that. Or, again, when you do an immunofixation test, those are not very specific. As the immune system is regenerating, you can get little clones that weren't even necessarily your original myeloma clone, and you don't want to be treating that, right? And so, again, it's also in part the measurement tools that we have to sort of follow those things and to know that we're actually not just flogging a patient, but doing something that's actually beneficial to them. Yeah.
So I'm always really intrigued by the gap that exists between centers of excellence and community oncologists. And as I watch this, I see, first off, incredible information and data, but it's also very overwhelming. And I think to myself, if I was a community oncologist, keeping track of all these things associated with every other solid tumor out there and other things, right?
Bingo.
So what do you see as potential paths to help get more of that expertise out into community oncologists? And then secondly, I think you're seeing more of the treatment options that you even referenced being available in community places, because some of these are not highly intensive the way that they used to be in terms of you travel to a certain location to do it. Yeah. So, I guess the aspect of that question is, are you seeing more and more specialists making their way into the community environment?
So I think, Jellick was saying that he wants the IMF to make available to all patients that kind of expertise, and what mechanism is there to do that. I agree. I mean, I can't fault a community doctor, for not knowing everything about every cancer. I mean, it's a lot. But I think that there is a role for referral. It doesn't mean you have to be treated at a center of excellence, but if there is one, within reach to potentially go to, I think that that's an opportunity in the current day. I think that, again, there is, we do education all the time. We, speak at various centers, but it is a lot, even to go to a community doc and expect him or her, just because they heard something once, for them to remember everything. And so, again, I think that that's where IMF is so important in really trying to sort of spread knowledge to patients and, have them consider, or have the, the info line to sort of have some of the nurses say, hey, maybe you want to, get an opinion somewhere. Every day people are sending emails, I have this tough, physicians that you've never met before, I have this tough patient, what do you think? There's more and more with virtual kinds of consults. That was big during COVID. It's harder across state lines nowadays. So it's challenging because if you have tons of, financial resources, you can tour the country and, get experts everywhere, but, most people don't have those resources. And so it's not very democratic in getting, the best opinions unless you just so happen to live in a place where there is an expert center.
And I'm going to just put a plug for our advocacy team. That is an area of advocacy that needs to happen, is to be able to have a cross-state line on a federal basis medical consultations.
Absolutely. And thank you for your presentation. Really appreciate it. So I noticed in your case study at the beginning it was T1114. I'm T1114. I'm just kind of curious if you are willing to share, how many here have the T1114 translocation? All right.
That's a high percentage.
My question is, when I learned I had this, it was opening some doors.
Yeah.
But also I heard from one expert or another that, this one, you don't get as deep response, or this one. How do you, so that kind of presentation that you showed for that one individual, I've been trying to find. And so are there databases of, I'll call them user stories, or patient stories that show what the progression is, and I'm T1114, what worked for this person? And then kind of related to that, in specialists, I knew there was a lot of research done at Emory Winship on T1114. Yeah. So it's like, how do I access those doctors? It would be nice if I could do a consultation across state lines. I do have Southwest points. I could go to Atlanta, I guess, but, and then kind of wrapping that up is I did see at ASH last year, some sonrotoclax was mentioned as a research done, I guess, in Australia and the UK, and just wondering if, just the T1114 landscape, if you can comment on that. Thank you.
Anybody who's immersed in myeloma knows the T1114 story in myeloma. There was a trial, the Bellini trial, which was doing Velcade and venetoclax in all comers, but they did the subset of the 1114, and they saw that there were higher response rates in the 1114. Well, actually across the board, higher response rates, but there were more deaths in the group that didn't have the T1114 or upregulation of BCL2. And, but clearly there is an improvement. So you don't have to go to only one myeloma center per se to get information about that. There's literature published and so forth. So I think that any community doctor, it could read these papers or whatever, and you have to get authorization, and there's a little squiggling or maneuvering to get it, but you definitely can get it, or go on a trial. And there are a number of different BCL2 inhibitors, next generation, that are in research, and time will tell, will they get approved and so on. But again, I'm not saying that, for example, in myeloma, that it should necessarily be first line, but maybe it should for translocation 1114 patients. Certainly in the amyloid space, which is a cousin to myeloma, about half of the patients in that population have that translocation, and it's really moved in a big way into that space, even though it's not approved and there are clinical trials ongoing, so we can get approval for that. So again, you don't necessarily have to go to the place where the research is happening, but you need to go to a place where they know that such a thing exists, and that gets back to the center of excellence. And a community doc, it's a little challenging for them to know everything about every cancer. I mean, myeloma, although second most common hematologic malignancy compared to things like breast and colon and lung, it's this big. So that's where you need to get some expertise. Yes?
Good afternoon. Thank you very much for your presentation. I'm a over 12-year survivor of high-risk myeloma. I have to say I've been very lucky in my unluckiness. I've benefited from a lot of treatments, most recently Carvykti, which I think is really a science fiction futuristic treatment. I recommend it to anybody who can qualify. My question is, what is in store for someone who relapses from a CAR T-cell transplant? Are you eligible for a second CAR T-cell transplant, or do you go to bispecifics? That's, of course, on my mind. And I have a more specific question. I know there was an Israeli study where they combined both teclistamab and tequaltamab alternating.
Yep.
If you know the results of that, and have they done anything to mitigate the ophthalmological side effects of those bispecifics, if you know anything about that?
Well, the bispecifics don't have eye things. That's belantamab, so that's the antigen drug conjugate. But in terms of these combinations, again, I showed you, some of those blue bars were some of the preliminary information on these different combinations. Most of these studies, you mostly have just response, and the follow-up is 10 months. This year at ASH or, at the IMS meeting, we'll probably get more follow-up. But it's hard to say anything really very specific about these things. It's just, it's interesting, it's promising, but where does it all fit? It's just too soon to say. In terms of what happens post-CAR T, there are definitely options, and part of it depends on what you've had previously. Again, the lady I shared with you, she had had prior BCMA. She had had the bispecific first because that's all that was available. She wasn't eligible for CAR T at the time, and so she had the bispecific. It did well by her, but we did, because talquetamab wasn't available, we didn't have a trial, and so she's like, I want to try the CAR T. It had been like 2.5, 3 years between the two anti-BCMAs. It did nothing for her. But she went to carfilzomib, a drug that's been around now for a decade, and that's working well for her. So kind of looking back, and what Teresa said about knowing what your therapies are, you don't have to quote them by heart, but if you could have them written down when you go to the doctor, and sort of, that's really important. That's like the most important part of a consult that I have with a brand new patient that's multiply relapsed. I want to know those details. I want to know, why did they give up on therapy X? Maybe there wasn't a really good reason to, and so you can circle back to that. But again, in this space to do, for example, talquetamab would, if you haven't had that, that's a bispecific, again, not against the BCMA antigen. That would be something of interest. Or a clinical trial with something targeting a different coding might be of interest. But even just looking through your history, is there something that we, missed? Or, maybe you used it, but maybe now it's been, 10 years since you had it. Maybe it'll work again. So it's a little bit like detective work and puzzle solving, and then also just looking what's on the horizon.
All right, so we are actually at time, but I'm going to take one more question and take a couple of minutes out of your break and the transition time between rooms. Malcolm is also one of our support group leaders.
Yeah, I have a different question. Someone who's been in remission for some time, hearing all of this, and becomes extremely nervous about when, oh my God, when is it gonna come back? what do you say to them?
Yeah, I mean, I think Jellic really pointed that out. Living with myeloma, it's hard. And, I say, look, first of all, you've been in a remission so long. That is a great prognostic thing. The likelihood that you're going to get in another remission, deep remission with whatever we do next is very high. And so, again, a prognostic thing, we talk about FISH, cytogenetics, LDH, extramedullary disease, yada, yada. But a long remission duration, is also a very positive, good prognostic marker. So, you try to reassure people, and you don't want the myeloma to kill you the day you have the diagnosis emotionally. Easier said than done, and some patients are masterful at, only thinking about it like the week before the appointment kind of thing, and they just live their lives and they sort of forget about it. But it is a challenge, and sometimes, counseling or whatever, but you want to, you don't want myeloma to, get the satisfaction of taking your life in a different way, taking your emotional life. But that is a challenge.
And I think you ask a really great question that everybody from smoldering throughout the journey really struggles with. And that's why we started the Smolder Boulder group for people who are living with the emotional or psychological challenges of myeloma without having myeloma, without having the physical symptom burden. But there has to be a day-to-day strategy for working with some of that anxiety, that stress. I know Tiffany's going to talk a bit about that today also, along with some of the other side effect management tools that we have put together as a Nurse Leadership Board. So with that, I believe we are at time, if not beyond time, but want to thank Dr. Dispenzieri for her expertise. Want to thank you for your participation and your questions, and we'll be transitioning from the newly diagnosed will be coming back in, and we'll be getting started with the next part of our session.